just means attendees can join. So keep your jokes good, Yeti.
Okay. I can entertain you with a song.
We're kind of used to the dance from you, but
Wise men say only fools rush in, but I can't help falling in love
with you.
Okay.
we can work on it, but I like the choir.
We are practicing from all angles.
Well, let me share you by that today we have a celebration in Mexico. It's a tradition where in January the 6th, we used to share a piece of bread with a little baby Jesus inside. And the person who gets the baby Jesus has to invite the tamales today. And I have to invite tamales today because I got the baby Jesus. So I had to rush for if I can find them. As you may imagine, everyone is getting
Everyone going.
rushed. Yeah, sure.
What's the name of the holiday, Fabiola?
Excuse me?
What's the name of the holiday?
Okay, in January 6th is the Día de la Rosca. La Rosca
Día
de
de la
Reyes.
Rosca. Yeah.
Yeah. And today is el Día de la Candelaria.
Okay. Qué bonito.
Don't ask me more because I'm not sure how the tradition exactly is, but it's very common here. Very common.
Lucky you.
Yeah, this is my third year in the world. I had to
Oh, you should buy the lotto now.
Yes, I'm thinking, I'm considering it.
You have something like this, Rosanna, in Peru?
Not Dia de la Rosca, but I was thinking of 2 days ago, there was a celebration of the anniversary of the wedding of my parents. And I was lucky me also, they selected me to keep one of the roses, to make these crosses of roses when the brides walk along. And it was so meaningful. It's something very beautiful in Latin America.
You can do it every wedding anniversary, or specifically like 50 years?
No, 10 years, 20, 15, no? But it's my first time I was crossing roses, and it was a white rose. I was so happy, you know? I just was so happy doing that.
Right.
Nadine, you recognize we have a holiday in the USA today. It's Groundhog Day.
Yeah, sure.
We will see what the weather the next few weeks are like because of the groundhog.
Yes. And Punxsutawney?
Yeah.
Punxsutawney, Pennsylvania. Very good.
Let me confess that picture, it's one of my favorites, and I see every time I can have the chance.
Is the big black head? Yeah.
I don't know if Jun Kun is on the phone. He is, and he can hear me. And I wonder if he has fireworks outside his window to show us from Chinese New Year.
Oh.
Yesterday.
Hi,
We'll
Elliot.
begin in a moment.
Okay. Oh.
Good morning. I will stay here in the background.
Good morning,
Good
everyone.
morning.
Thanks everyone for joining. Dr. David, take it away.
Good morning, good afternoon, good night, wherever you are around the world. Thank you for joining us. It is an exciting day for being part of a webinar. And I'm saying being part because you actually expected to participate. This webinar is different. It's a town hall meeting, meaning that it's informal and intended to be interactive. We have extremely highly qualified faculty in front of you. We are sitting on like a high bar stools, and you are sitting around us, and we will talk to you and listen to your question and to your comments. So it's going to be a different style, but very exciting and interacting. I look forward for that. And for the subject today is what we want to do is want to take the global clinical engineering village and share with you the priority and goals that we have learned over the last few years, and we'll tell you from where, and where do we go from here and how you can be part of it. In addition to this webinar, it's also a very interesting start for our friends over in the Pacific, where China is celebrating their new year. And I'm sure they are now ready to get on with joining the goals and participate in the activity of the new year. Also, I would like to take the moment and say that while we stand in front of you, there are volunteers working behind and making sure that you hear us correctly, that the screen is bright and focused, and the slides are moving along, and the internet is opening up. And looking at that, it's talking about internet opening up, your ability to participate is conditioned on one thing. Learn on the bottom of the screen where you can raise your hand. You should have a button with actually saying raise hand with a signal like that. When you put it up, when you press on it, we will get a signal that you have something to ask, comment, or share. So during the webinar, we can't have open mic and make a chaos and noise every place. But if you want to participate, and hopefully you do, please raise your hand and we'll give you the microphone. So with that, let's go ahead and start. Our agenda will be to have each one of us informally talking, and we'll talk on top of each other and into each other and with each other. It's going to be fun. It's going to be informal setting. And I will start setting the stage. Fabiola Martinez will come after me and give you the academic angle to our discussion. Then Tom will join us with essentially the specific goals and priority that we identify at the Global Clinical Engineering Summit. And then in between, we will have a polling questions. We'll ask you a couple polling questions, and we'll come at the end and pose another questions to see how much progress we made.
Nadine, you said we could talk over each other. I'm happy that you're going to have some jokes very early. I'm looking forward to those. Back to you.
Oh, I'll tell you about one. There was a webinar the other day, and this group came in and wanted to present informal material. And the priest said, no, that's not a good joke. Okay.
Okay, well, we'll do that one later.
After Tom, we'll have Rosanna, and Rosanna Rivas will take us into the actual relationship with a government agency, with federal programs, and how clinical engineer can participate in that, and that it's not that easy. In the background, we also have a part of the faculty is Elliot Sloan, and Elliot Sloan has a variety of topics that he is expert in. One of them is digital health, and he will join as question and topic are coming up. With that, let's go ahead and set the stage with the next slide. Thank you, Kali Roy. The essence for our meeting is because we, the clinical engineering professionals around the world, have an essential role in healthcare delivery system. However, it's not that clear, unfortunately, to ourselves, also to others and to the public. And you will see the summit goals and challenges identify those very clearly. So this ecosystem and the policy that guide it are changing significantly, especially in the last 2 years. I don't have to tell you that, you all know that very well. But these challenges that are being created, this change, are also an opportunities. I want to show you on the right-hand side of the slide, we have a patient who is calling for a nurse, and unfortunately the bed next to him is a nurse, and she's saying, yes, what do you need? We all get sick. It doesn't matter if you near, far, rich, poor, black, white, male, female, we all get impacted. And we all are getting stressed, as the cartoon below showing that the healthcare worker is trying to hold the cable of the healthcare system together. This stress provide opportunities. This nurse sitting in the laying in bed provide opportunity as well as challenge. The challenge of workforce capacity is of course there, but the opportunity is for clinical engineers to come and say, here we are, here is what else I can help the system with. Here is the competency I can bring to the table. The clinical engineering community are part of the orchestra. The orchestra is the healthcare system. If you take the violin out, if you take the conductor out, if you take the cello or the drums out, the music is not the same. The concert is not complete. Every musician is critical, and we must strategize to know how to play in this orchestra. To be a musician, you need to learn, you need to practice. We need to know how to play in this evolution. We need to understand the group, the orchestra role, and how each one of the musicians get in and out in different parts, and be able to measure the rhythm. When you're getting in, when you're getting out, what's the impact? And publish that and document that. We need to prepare for the concert, be ready, meaning competency and interaction, and we need to understand the notes of the music. Specifically, and I'm taking a discussion we have with Dr. Manish Kohli and modify it a bit, we have areas that we would like to share with you. Those are, first of all, patient outcome. If we don't have any impact, any influence, any improvement because of our engagement in patient outcomes, we are not in the right business. Access to care, access to service. Just think about what happened with telemedicine overnight. 5 years ago, you could not give telemedicine for free. People did not want it. Today, you don't have enough system. The system is not complete sufficiently. So access to services overall is becoming a worldly global phenomena. And the quality of it is not just how good the care is, but also how safe, how we eliminate the risk and manage the risk. This is should be one of our strength contribution. You can talk to Ministry of Health without bringing cost, financial impact, and show that we can contribute to the system being more efficient and of lower cost and keeping the quality high. We need to be able to demonstrate and need to be able to measure that. And finally, ourselves, the workforce, competency, capacity, availability, reliability, and collaboration. Learn how to go and be part of a hospital committee, be part of a global standard building organization, be part of teaching a course, come to the university and volunteer to share your practical experience with the student. These are all gold nuggets, very important. And therefore, I think that what I'm telling you is that we have a tremendous opportunity at this point for our profession to grow and be part of healthcare like never before. And we should take advantage of that, because this opportunity will be taken by somebody else if we are not coming through with it. Fabiola, I'll turn it over to you.
Thank you, Dr. Jadin. I think you have shown a very clear framework from the situation that we are dealing with today and the opportunities that are ahead of us. And trying to complete this exposition, I would like to talk a few minutes about the academic point of view. First of all, I would like to state that it's very important to be aware as academics that we have a limit in time by trying to prepare our students as a good biomedical engineers and clinical engineers. And it drives to a discussion about how many and what kind of courses we should teach at university. And this discussion has been developed along the way, and many statements has been expressed. But I think we may come from the fact that our students come to us eager to learn, and also eager to know what a biomedical and clinical engineering can do outside. So it's our responsibility not only teach them the basic, the core courses of electrical engineering, for example, but also to let them know what the reality is, what the challenges, the real challenges are outside, and how they can deal with it with our help. Yes, with the help of the professional clinical engineers, but also with the help of the academic staff. So thinking of this, I can see that we are going through a very important change in the way we look this dynamics, no? in clinical engineering. Historically, we have dealt with a kind of a stable framework where the activities of a clinical engineer were focused on operative functions like maintenance, management, medical equipment control or training, and lately certifications and so on. So we have been performing operative functions, but also we have tried to get involved into more complex activities at hospital, like development and research medical device, design medical device also, and develop systems for physiological measurements. But this framework have dramatically changed to a very ultra dynamic one where we have to focus on context. And the context means that we have to be aware of skills like high-level management, strategic planning, as Dr. Jidin said, risk assessment, but also to be familiar with some topics that may not be very linked with our day-by-day functions like public policy, regulations, global health trends, and economic factors. So these topics have to be on the table and have to be discussed with our students. The earlier we do this, the better they will be prepared in their professional duties. And it's not easy to design academic programs with so many topics. No, it's not easy to let them know in 4 or 5 years all of this knowledge and data and so on. So what we discovered is that the help with organizations like clinical engineering divisions, that national societies of biomedical engineers, and also the groups of clinical engineering, and by sharing the knowledge via education, continuing education courses or webinars or workshops, and so on. And by inducing our students to have the learning for life culture and preparing every day and evolve with the discipline, this will be a very important point to discuss and to develop. So this is the future of the clinical engineering. And so this is our responsibility.
Great cover. That's great. As I said in the beginning, we have a polling questions. So maybe Tom, if it's okay, before we jump to you, we'll put up the polling question. You can choose one answer.
Anything you ask, the answer is yes.
Wow. Wow. The love is growing. So in the polling one, you have two questions. Are you practicing at? We want to know if your questions will come from being part of a hospital, medical center, academia, industry, government, or others like consulting and so on. And the second question, and you can choose only one answer for each one of the question. Have you been involved with clinical engineering, health technology management field? We just want to know, are you novice, you beginning to? Are you senior, you working there for many, many years? Or I came here to learn, I don't know even what the field is all about. So please take 5 more seconds, mark your answers, and we can show the results as soon as Kaliroy is ready. We have on the fantastic 41% are practicing in medical center or hospital, 12% apparently loving Fabiola from academia. We have 3% from industry. Excellent. We love to see 5 people or 15% from government and other practices, almost 1/3 of you. The second question.
Forgive me. Even family members make mistakes.
Not yet involved. 10%. Excellent. We love to show you how to get involved. Beautiful. And half of you more than 10 years in the field. We depends on you to make those changes we're talking about today. Tom, take it over.
Well, I invite everybody into my office area. You see the couch here. I've got the silk road over my hair from Xi'an, Allen to Rome for our Italian friends behind me. And welcome. I'm excited. I sent this link. Many of you know of the WHO regions around the world, and this link that I sent you tells country by country where people fit into that. And that's a good backdrop for the discussion we're going to have. One thing we wanted to do today is give you, and we want you talking in the next 5 minutes with the open mic. So this is going to be very brief. We sent this out ahead. Perhaps not all of you got this. So CED has been around a while, but in the modern era since 2009, when Dr. David here was the chair of this group, and then a couple others before me, Dr. Khalil and Iadanza, and then myself since 2018. And in 2019, Dr. David started congresses with our Chinese colleagues, global congresses in 2015, and in Brazil 2017, and Rome 2019. And then we did a virtual one, many of you know, last October 2021. And at those times, we have a global summit, and we bring countries together in our professions, our colleagues together. And yes, we're engineers, and yes, we're hospital-based, but we're also physicians in this group that lead health technology work. We're also other kinds of health care professionals. You know, our desire is to make a difference at the Ministry of Health level. I know there's several of you here representing Ministry of Health. So let me dive into this a little bit. So what's the historical perspective on our discussion today, which is, as Yadin said, we're family. I invited you to sit on the couch here with me and have this discussion. He said bar stools, I said couch, whatever works for you. But when we got our colleagues together in Rome, what did we say were the key challenges in our profession to make a difference, not just to hug ourselves, but to embrace the world in smart ways? And remember, this program I'm beginning to describe now was in October 2019. Think about the timing. We were growing, we were making a difference across those 6 regions of the world, but COVID had not hit yet. So this was just pre-COVID, and then a lot of our impact since then has been as a result of stepping up and making a difference during COVID times. But so what is the IFMBE Clinical Engineering Division, and more recently our partner, the Global Clinical Engineering Alliance that Dr. David leads? What we represent, this global clinical engineering village, global health technology leader village. What are our key priorities? What are our key challenges? Well, partnering with Adriana Velasquez in the WHO Medical Device Office is at the top of our list. And just, I'm not going to go too much detail, but increasing our role in decision making. That's, we're going to look at the 2021 results of this discussion and what we want to do about it in 2022. One of the leading areas is impact. So increasing our role at the Ministry of Health level, typically, or the health leader level, is about impact. Ongoing training and education, or initial education, I should say, and ongoing training around designated clinical engineering competencies, we said back in 2019 was huge. And that's in the area of capacity building, one of our goals today. Ongoing challenges around professional recognition. Lack of policy at the national level related to medical devices and their safe use, clearly about policy. Standardizing, our terms in our profession. Some of you are called clinical engineers, many of you are called biomedical engineers, many of you are part of biomedical engineering workforce in some fashion, maybe even physician leaders of that. We need to standardize those terms so that we all can speak a similar language. And we also call that body of practice, body of knowledge. Our CED, GCA, the Global Village is about enhancing your national associations. Fabiola mentioned she's a part of SOMIB in Mexico. I know there's folks from Brazil and Argentina and on here today. We want to enhance SABI in Argentina. We want to enhance your national associations. We want to encourage things like smarter design into equipment in the first place. And we have the ability to work with industry and work on that kind of impact. We're very involved in medical device regulation. That's at the policy level. And lastly, everybody wants to ensure that people working for them have the right credentials, have the right background, and they've been tested to ensure their competencies, and that's credentialing. So those were the things we talked about on the left of the screen in 2019, and that's the scores that were assigned by the 50 or so countries that were represented there in October of 2019. And one question we wanted to answer today is how have we done? And you can see our answers on the right. In March 2020, we stepped up at WHO's invitation to be a strong partner with them during COVID. In terms of increasing our impact, we've had this huge response, 40 plus webinars with really over 50 webinars with WHO since March of 2020. We put out a daily newsletter about vetted and peer-reviewed articles that are relevant to our field. We held this Congress with 128 countries last October 2021. 128 countries were a part of that, and 2,100 practitioners. We've held all these training webinars around competency. We've got the Global Clinical Engineering Journal. This is a long list. I've sent it to a lot of you. After this, we'll send it, those of you that we missed, to others of you. We've been engaging with healthcare leaders globally the past 2 years, Ministries of Health, the International Hospital Federation, the Every Breath Counts Coalition. Some of these are familiar to you, some are not. You can look into it more later. At the policy level, I'm remembering the article Dr. Jatendra Sharma from India wrote about affecting health technology policy in India. That was in the Global Clinical Engineering Journal. And also we've engaged with various healthcare leaders around policy. And I'm thinking of the International Medical Device Regulators Forum. I'm thinking about the Food and Drug Administrations in the US and Mexico. For example, we've been working hard in the credentialing area, more on that. We've been helping create as well as encouraging the growth of societies. I'm thinking of the creation of one in Pakistan a couple of years ago during this time period. You know, affecting equipment design with industry is a tough nut to crack, but we've, you know, there was a challenge during our last Congress about how to make all these designs for COVID devices open source as we move forward. And, you know, have we been involved in regulation? Very much so. We all know with the COVID challenge that the emergency use authorization around ventilators and things like that has been a big deal around the world, and so on. So, and we've had these body of knowledge, body of practice surveys. A little bit later, I'm going to come back to this slide and talk about, so how can we affect things? How can you those attending today in your countries, in your regions, how can you impact capacity building, measurable outcomes, credentialing, and policy? And we'll have some information about next steps at that time. I'm going to switch.
If you recall, we have collected successful story and case study in 2016 and presented that to the World Health Assembly, which is the event at WHO. And Kaliroy, if you can put the article, we published the results, and it's a good tool for us to use and remind ourselves that we do have a case study to demonstrate. Here is specifically how we impact outcome, patient care outcome. Kali, if you can put it up for us, that'd be great. Thank you.
And Yadin, let me tell you the good news and the bad news as a family member about that. The good news is it's, wow, 400 submissions, 125 countries. This was published, I believe, in 2018, as we see at the top. There's been a lot going on since then. You know, I said a moment ago something very important is how do we, at the end of the day, how do us health technology people, our village, how do we impact clinical outcomes? I mean, there's a lot of steps. Those of us that have also come out of the quality world, there's a lot of steps between, you know, intervention and process and actually affecting patient clinical outcomes. And so we talk about many things on the continuum between what it is we've done and how it literally improves patients' lives. I think there's going to be many more studies that have come the last 3 years. We need to capture those, and we need to capture those with our audience help today. Yadin?
Let me remind people who join us later than the start of the webinar, when we mentioned that at the bottom of your screen, there is a symbol looking like a hand, said raise hand. In order to open the mic and let your comment be heard by everyone, comment, questions, or sharing of experiences, we need you to select that, and then we can pass the microphone to you, just like we do in a town hall. I would love to get Rosanna's input on interaction with federal agency. Rosanna, please.
Thank you, Yadin. It's really exciting to be now with all of our colleagues from diverse countries and contexts in this important and valuable opportunity to discuss, exchange, and make some conclusions at the end. I know that time is not going to be enough, as always happen, but it will be very meaningful and pertinent. These 2 last years have not been ever, they have not been less than challenging, less than difficult, and also demanding a lot from us clinical engineers to be not just with high level of knowledge, but also be enough smart to change, adapt, and interact correctly. And in this process, make a correct evolution to how to match with the interest of the different stakeholders, talking about government and talking about agencies and non-profits. Those organizations have an agenda and priorities. Clinical engineers, we have been able to deal with all of these diverse contexts and also agendas to show our value and make interventions sustain. As Thomas stated, and also Yadin, we have diverse success stories which demonstrate our valuable outcomes in this field. And it is now the opportunity to make a conclusion, a global conclusion of what were the best steps and what can be the best next steps to do. COVID-19 set for all of us clear priorities to achieve. And we were able again to make our presence visible. Some of us in the policy arena, others on the regulations committee, other ones in the academic board inside of these organizations, government and agencies. This is the way to make the best to change the role, but to be sure that our contribution is in the table, is part of the discussion, and hopefully will be embraced in the decision-making process of these organizations. For a little example, some countries like Peru is now in the middle of a new, again, change of government. All the ministries will change. And again, the story will start again from zero. I hope not, we hope not, but see, colleagues like us who has been working sustainably, no matter who is the president, knows pretty well that being in this kind of events, being part of these amazing CEDA, FMBE, GCEA organizations makes the difference for us to be ready, inspired, and most of all,
Great.
with a kind of leadership shared. Thank you.
Great. Let's cover another angle of the circle we're in. Many notes in the orchestra. Important one is the relationship we need to build with government and federal agencies, as well as international organizations. Tom, do you think we can jump into, as we are waiting for a question, to areas of involvement? Where can the audience can be?
Yeah, I'm gonna frame one more thing and then jump into that, Yadin. And by the way, I just sent to everybody, I note that everybody in the audience today did not receive these documents ahead. And so I attempted to send them through a Zoom, and maybe you can open them and look at them. One's an Excel file that I'm looking at right now, and the other one's the Word document I was looking at a moment ago that set the stage today. But the 2021 summit, and so we're going to get to the open mic and the what people can do in just a moment, Yadin. So what did we say in the Congress last October? We said capacity building and impact measurement are our top two professional goals, organizations, the global CE Village goals. The lack of uniform body of knowledge and practice, professional recognition, professional standards, and the role of national societies. Next, Antonio Hernandez is in the audience today, 20 years at Pan American Health, a guru for Latin America health technology. He and many others echoed the need, particularly to be involved in policy at the national level with ministries of health and other health leaders. We all know governments change. I think maybe Rosanna was even talking about that. And so the ministers change, and hopefully I'm not saying something that offends anybody, but there's health leaders, there's academia that keep the continuity going in countries over time. But our profession needs to be more and more involved in policy at the national level. And there's several of you that represent ministries of health in the audience today. We have an initiative this year to take our involvement in a really intelligent way to a higher level. And as I mentioned before, the WHO partnership and so forth. So those are our priorities going into 2022 that there's various next steps shown here. A lot of the ways we educate is best practices through our webinars. We need volunteers in a variety of areas here. The Global Clinical Engineering Alliance has webinars that are very significant. There's other entities that have webinars. Dr. David could talk later about how we're going to partner with the health technology assessment leaders around the world in a variety of ways. But so Yadin, maybe we can open the mic and then I will begin to show people how they can get involved, if that's okay.
Great, yeah. Please, if you have any experience to share with us that relate to these priorities items, the 4 priority items you see on the left side, something that you have done that you believe work towards that, that would be nice experience to share with the group here today. So select raise hand, let us hear your experience, or if you have a question, how can I get involved, for example? We will love to hear that. So go ahead, let us know. You're in danger that if you're not raising hands, we'll play commercials until you do. So
Yadin, Antonio has been unmuted.
Go ahead.
Hi, Yadin, Tom. Great start of the year with a lot of possibilities to move forward. I just want to add a couple of points to what Tom said about public policy. Probably most of you know that I have been lately advocating for the importance of the clinical engineering to be more proactive in the national arena in order to help to build public policy in health technology. An example, something that you could immediately start working with if you are not doing so, are the 2 big initiatives and decision of the World Health Assembly of the World Health Organization that is bounding all the countries and will have a very important impact in our profession. The first one is, and is right now over the table, is the nomenclature for medical devices. Has been a very important input for the community, but that is not one-time shot. It's something that everyone at the country level and at the institutional level in the country should be involved, because nomenclature will impact the field of health technology. The second one, and it was from the last year, the decision or resolution of the World Health Assembly regarding the countries, all of them committed to move from the CDC-10, the classification of disease, from the 11th area to the new one, from the 10 moving to the 11, and that have changed the scenario of how disease has been classified, and also technologies involved on that. And in doing so, also that will have an impact in how clinical engineer and health technology managers approach this change to adequate the programs to how new technologies and old technologies need to be reaccommodated to be in line with the CD 11. That
So
is
International Classification of Disease, ICD-10 and ICD-11, which is all the interventions that are very technology based. Go ahead, Antonio.
Yeah. And as I say, although several countries already has been working since some years in ICD 11, there are probably the bulk of the countries not in the ICD 11, but just start moving to that. So you need to read the research and work on this at country level. And there are, as Tom is showing, information in the World Health Organization website. That is what I want to say. Tom, Jadine, thank you.
Great, Antonio, that's very important. And I would ask you to follow up and tell us, here's a question from Saudi Arabia clinical engineers who would like to volunteer and address these issues. How would you suggest for somebody who just individual practicing in a hospital to start getting involved?
I love that. I can respond, others can, go ahead.
No, I would say that this is part of the concept paper that I am preparing in how to assess and track the evolution of health technology in country level and globally. So there will be a lot of information that we will be gathering about this. And as I say in the previous meeting, of the collaborators, I will be asking for input from some of the members. There has been a large group of members that has stepped in order to collaborate in this initiative.
Great, thank you, Antonio. And Tom, Abdulaziz is still waiting to hear the rest of the story. So go ahead.
So under in the documents I just sent you, so you can look at these later and consider them. If we want to be involved in capacity building, for example, one thing CED, as you've heard us say, we facilitated and partnered and developed a lot of best practice webinars in 2020 and 2021 in particular. In 2022, starting in March, we're going to work with the different regions, the 6 WHO regions, and our colleague from Saudi is, of course, from the Eastern Mediterranean Regional Office, IMRO, as it's called. And this, by the way, I'm going to use these acronyms down here: the Americas, Africa, Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific. And I think most of you online know which region you reside in, but all 6 regions, we're going to begin a what I'm going to call monthly webinars starting in March, where we gather people from those regions. So there's going to be an IMRO webinar, as well as the other 5 regions at different times. So imagine a 1-hour IMRO webinar in March that CED, GCEA, the alliance that Dr. David represents, CED that I represent, we're all here together. In March, we're going to gather individuals as well as societies. I know in Saudi, Dr. Majid Noor is head of the Saudi Biomedical Society that's very clinical engineering focused, for example. But so we're gonna the outsiders, you might say, are gonna facilitate a meeting in March to outline issues, say for IMRO. But in April, we want you to meet without us. You don't need us to be at the table for all your discussions. Maybe you'll have the discussions in Arabic, any way you want to do that. It's region by region. But so I'm imagining over the next 6 months that we will facilitate a monthly meeting of IMRO, and all comers where your voice can be heard, and from the person that's the highest ranking clinical engineer in the country to the lowest ranking. It's, we want all those voices to be heard during those monthly meetings. So one meeting, the globals will facilitate, the next meeting, the nationals will facilitate. So, and then you may say, well, IMRO's got, 25 countries in it. It may be that, we're happy to use our Zoom platform to help you, have Saudi Arabia specific meetings where, we'll help set the stage and, help you make those meetings happen, but the content of the meeting will be yours. So I'm imagining maybe 3 globally directed IMRO webinars over the next, brainstorming sessions like this one today over the next 6 months. And 3, IMRO will set those up on their own. By the way, you may say, well, okay, how is that different from the past? One thing is we've got great connections together. You've got connections, I've got connections, Dr. David, and our connection. And what do I mean by that? I mean, one of our colleagues, a physician leader whose name was mentioned, Dr. Manish Kohli, is on the board of Arab Health. So the Arab Health, many of you recognize, like Africa Health that you recognize, is many of the decision makers and health leaders in those various regions. So we've got connections to those leaders, so we can get your voices heard by those decision makers during these meetings over the next 6 months. Yadin, do you want to clarify any further?
That's great. I think that there are some specific steps individual can take. The Alliance, Global Clinical Engineering Alliance, have committees relating to education, credentialing, capacity building, policy, but you need to be a member to participate. Either your national society, or if you don't have national society in your country, as individual, you need to be a member to participate. And otherwise, with the Clinical Engineering Division of IFMBE, there are many task forces and project work that is done on one individual base at a time. So you can write to Tom and suggest that you would like to volunteer and let us know what the specific topic you're interested in. So for those on the audience that would like to know, how can I as individual participate? Those are the 2 categories. We would love to see that we come to your area, to your region, and have hopefully soon a face-to-face conference. If COVID will not allow it, we'll do virtual conference in your region, and then you can help organize it and facilitate the hosting of it in your region. That's another way you can propose that you would like to participate and help with. And with that, I can ask Kaliroy, maybe you can put the next polling question and see how the audience stand on those. And the next polling question, thank you, again, have 2 questions. You can select one answer to each of the questions. Are you aware of the challenges faced by clinical engineering and health technology management practitioner in the field? You are not, you're not sure, you're here to hear about it and learn. The second question, do you want to be further engaged with any of the projects discussed today? And yes, no, not sure, interested, but don't have the time, or not relating to my practice. And again, you had, we have posted the Tom's email address, my email address, this webinar address. You can all communicate to Fabiola, Rosanna, and Elliot in the background as well. So let's have 5 more seconds for answering the polling questions. Okay, let's take a look at the results. Look at, are you aware? Yes, I'm aware, and I'm participating in related project, 43%. 46%, majority of you said, yes, I'm aware, and I'm looking to hear more about how can I get involved. I think those 2 answers are significant, because I would like to hear from those who said, I'm aware of the challenges and participating in related project. Let us hear from you right now. And the second question is, do you want to be further engaged? Over half of you said yes, and I will contact you. Yes, I didn't decide which one yet, and that together is 82% of the audience. 10% or 11% said not sure, and 6% said interesting, but not really related to my practice. Fair answer, I accept that. Let's go to the over 40% who said, yes, I'm aware of the challenges and I'm participating in related projects. Let's hear some of those case examples. That would be great. Anybody that care to raise hand and tell us?
Yadin, to get that started, Fabiola not only is a board member of CED at the global level, but has for a long time been a key leader in the Mexican Biomedical Clinical Engineering Society, SOMIB, and she's going to tell a little bit about how they connect to this global work. Fabiola?
Oh, thank you. Yeah, for many years we have been struggling, and the Mexican Biomedical Engineering Society by positioning clinical engineers on the stage and providing the value they have. Fortunately, in the last administrations, the awareness about the importance of clinical engineering has risen, and that led us to take a more important participation, not only in the society, but also in the activities of the Ministry of Health, for example. We just recently changed administration at SOMIF, and the new president is more than willing to share the stage of the SOMIF to not only to the Mexican clinical engineers, but also to the clinical engineering world. And we are working on designing the best ways to perform our activities in the official forums of the SOMIF, but also of the official forums of the CORAL, that is the Latin America Biomedical Engineering Council. So some of the direct activities we may perform on these scenarios are the participation of special sessions on their congresses. Last year, I had the opportunity to propose a special session at the IEEE for clinical engineering from the IFMBE and from the clinical engineering division. And we participated as the federation representation with very nice results. Elliot was with me in a very nice conversation, and also Ernesto Yedanza participated with a video, and also Almir. So we had a very good first step into the IEEE, and this example was a point from we can participate not only on the National Society Congresses, but also on the regional ones. This year we will have to our Latin American Congress on biomedical engineering, and we are also working on participating as a group with special sessions or with workshops. So, and also with papers, no, with presentations of original work. So by doing this, we make presence. We are known as a group and as a community, and we disseminate the knowledge we are developing, and we are letting them know that clinical engineering, it is not only operative functions, but it is also strategic, and it's also a field of very important research in the hospital. So this is what we are trying to do, and I am expecting very, very good results.
Thank you, Fabiola. This is a very important comment to understand how it's evolving and how much work it takes to get the group connected and acting, something that Antonio is working on as well. So let me jump all the way across the globe to Bangladesh, where it's middle of the night almost, and before people go to sleep. We got a comment from Anwar, who's saying that he is involved with Ministry of Health, with other stakeholder, and has an example for us. Anwar, if you can make it straight to the point, please.
So we have to unmute him. Let me see real quick. Yeah. Anwar, go ahead. Let's see.
He's still muted.
Calroy, you can help if you can.
Anwar, can you push the raise hand so we can give you the microphone?
He has the microphone. Please, Anwar, unmute your microphone.
Unmute, unmute. That's it. Okay.
He may not be in a voice connection.
It's, as I said, it's late at night.
He's now got a voice connection. We just need him to unmute.
You're still on mute. Let's move ahead until.
Hello,
There we go. We hear you.
welcome.
Go ahead, sir. So Anwar, you've put in your note.
Hello, are you hearing?
Yeah, we hear you.
Hello,
Yes, go ahead and speak.
yeah. So, welcome to all. I hear the speech and voice, learned voice, is corner. So the condition of Bangladesh clinical engineering issue now enhanced.
We are losing you and it's difficult to hear and we need to move with the program. So let's move ahead until you figure out the audio.
And Yadin, I'll mention that one of the things we asked the countries to do if they could, and this date of January is passed, but so Poland submitted a country status report, SBEB in Brazil, CEAB that Anwar represented in Bangladesh, and one other here I've got open. And so a very nice story about Bangladesh and their National Clinical Engineering Society, CEAB, is able to be opened by everybody. And if they open it, it looks like this, CE status report, and it talks about how the Ministry of Health of Bangladesh has started to recognize biomedical clinical engineers, started to hire clinical engineers and biomedical equipment technicians into the Ministry of Health hospitals, that they've got a strong program going at the universities, training new biomedical engineers, clinical engineers, and they are engaged with stakeholders of all kinds across that government. So it's quite a success story.
Great, good case studies. Thank you, Anwar. Sorry for the audio problem, but I think that the message got across to the audience. And
Yadin, I'll just mention quickly that there's been similar stories published that people can open from Poland. Eva's here on the line with us, and one of her bottom lines is and we want to help her organize their association, Clinical Engineering Association of Poland. And there's different people are different places in the continuum. And then there's our friends from Argentina, from SABI, that, how can they build on the great work they have there? Maybe tighter with the Ministry of Health, who's here on the line here today from Argentina. So these are some of the case studies. Back to you, Yadin.
great. And this is an indication of what we're going to do later this year in October. We're going to work between now and October on country level involvement with Ministry of Health and do a case study to be presented during the Global Clinical Engineering Day, or as it turned to be a Global Clinical Engineering Week. We would like to
keep going with that idea, because before I was saying we only did these annual congresses every 2 years. Are you suggesting we're going to do one every year now because of growth?
Yeah. We got so many people doing so many good things that we need to share and encourage that. From Fabiola and Rosanna to Antonio to Elliot, to Anwar, to Abdulaziz in Saudi Arabia, to Shen Kun in China, and Keiko in Japan, and the list goes on and on and on. And we're not sharing enough. It seems like we are reinventing the wheel every time on our own, while there is a wheel out there that has been invented. We just need to imitate that.
So let me build on what you're saying. So I talked about, every 6-month programs beginning in March. Well, that ends in about September, because we want people to present the results of that in October during Global CE Week. And so we can imagine, a Global CE Week that's very focused on policy and capacity building and impact, like you were saying.
Exactly.
Over to you.
Exactly. So every 2 years, we'll continue with the International Clinical Engineering and Health Technology Management Congress, like we did in October 2021. And we'll move it around the world, virtually or in presence. And then in between, we'll have opportunity for annual Congress to be focused on specific subject, not on the whole field, but on specific subject. And for the 2021, we are proposing to focus on policies and capacity building. Those two.
You said 2021, but you meant 2022. Just a family member patting you on the back here.
I'm testing to see if you're listening. That's okay. You passed the test. Thank you.
You're welcome.
So we would like to focus on those in 2022, and definitely we need volunteer to help us to organize the program. Any other comment from the audience?
I think there's a big elephant in the room, and I'm not talking about anybody's size. I'm talking about digital health that's changing the way healthcare is delivered. And part of that's cybersecurity, part of that's telehealth, but there's many other things about that. Dr. Elliot Sloan, come on down. Tell us about what you see. What can this profession do to change the way healthcare is delivered, Elliot?
Okay, I very briefly, there are so many changes happening in our field that are accelerated by computing technologies, whether it's decision support, machine learning and artificial intelligence, remote care with telehealth, medical care, a wide range, and also the integration of data within the hospital and health systems, and also population health, which has been such a critical part of confronting the pandemic. Sort of laced through all of this are the concerns of privacy, security, and availability. Well, once you commit to electronic systems, they have to be robust and available. And we are seeing growing hacking and ransomware attacks on public and private information systems. There are many opportunities. These are, in my mind, all clinical systems. They are not the kinds of systems that our general IT or ICT colleagues are familiar with. They may be very familiar with financial systems and business systems, but the clinical impact, the life and death impact, the breath by breath impact of these systems is really in our court. And we have to define that. We have to continue to define that. And we have to continue to find ways to build bridges between us and the various colleagues and components. I'll just also suggest that there's some very innovative solutions coming out of low and middle income countries, and they are a source for what we describe as reverse innovation. We can adopt and adapt some of those systems to many other settings. So there are many opportunities, perhaps just thinking off the top of my head, the Global Clinical Engineering Journal might be a place where we begin a periodic column that talks about some of these innovations. And I think we have enough skills in the global community to begin sharing this information instead of trying to start from scratch. So there are many things we can do. I'll leave it at that. Thank you, Tom.
And Elliot mentioned a very good channel for sharing knowledge, and that is the Global Clinical Engineering Journal. Elliot himself accepted invitation to submit editorial comment and editorial column, and did great job on specifically how we should get focus on childcare. And I invite you to look into the journal in general and specifically about the column that Elliot put as a guest editor. All of you can contact me and let me know if you are willing to volunteer a manuscript or a technical comment, or be a guest editor to write a column that basically express opinion about the subject. That would be great. Barun put a comment in the chat box very kindly that he said, just tell me where can I contribute? I'll be very happy and pleased to do that. Ask me for anything. And I think that what I would like to do, Barun, is just let the audience a little bit of the background about you. When you said, ask me anything, what is your capacity? I know it's late over there, but if you can stay awake and tell us, that'd be great. Barun?
Let's see, we have to open his mic here. All right, Barun, you should be able to talk.
Hello.
Yeah, we hear you.
Hello. Thank you, Yadin and Tom. I am Barun Kumar from Nepal, biomedical engineer, and I have been working in the nationwide maintenance project in Nepal here. And I have worked a little bit with Adriana, under the supervision of Adriana, in last November, December, and now involved in few biomedical activities in WHO CRO region in Delhi. So my main expertise is more related with the oxygen ecosystem and maintenance management. And I have a little broad knowledge about the lagging part in the clinical engineering field in the low and middle income countries, especially for I have experience in Nepal. So these things are I know, I think from the ground level.
Great.
Thank you. I think.
And Barun, you were very helpful in giving us a review of innovation to address COVID-19 challenges with technology that submitted for specifically transfer it to low resource setting. So thank you for doing that. Tom, you have Dr. Maombi.
Well, Dr. Edison Maombi, from the African region, I don't know if a medical doctor very involved in health technology, I don't know if we can invite you to speak, sir. Crazy time of day for you, we recognize. Let's see if I can open that up for that possibility. I'm looking hard.
Barun.
Here we go. Dr. Maombi, I've opened your mic if you might make comments. He's on mute. He may not be in a position to do so, but we welcome you, Dr. Maombi, if you can. Yadin, do you want to mention a bit more about that compendium you were talking about? Baron was one of our team members there.
Yes, this is something that, thank you, Tom, that we are very proud of. Collaboration between Clinical Engineering Division of IFMBE and the Global Clinical Engineering Alliance resulted in presenting the clinical engineering expertise in evaluating and assessing technologies that were submitted to address COVID-19 challenges in low resource setting. Those submissions came to World Health Organization and proposed to transfer intellectual properties and patent rights to be locally manufactured in different countries that are part of the loss resource setting. The technology need to be reviewed. Are they sufficiently appropriate? Are they safe? Are they have sufficient human engineering factors and will not contribute to increased risk? Is it easy to maintain and service? Do we have manual and spare parts that are going to be accessible in those locations? Do they address clinical needs, or there are other alternatives that are better? All those were put together in a survey that Tom and I crafted and distributed to volunteers in those settings. And we ran a review of each technology. Then Tom and I summarized the responses, and created a portfolio of evaluation on the engineering and technology management issue for each one of those submissions. We identify issues that were not, we identify submission that were physically not reliable. We identify submission that were excellent solution to a local problem. We identify solutions that cannot be maintained in those settings, et cetera, from oxygen generation to personal protection gears and to digital application of different solution and tracking of diseases. It came out in a book that World Health Organization has published in 2021. Here is a sample, and a second one for 2022. It has been finalized literally this week and will be published soon by World Health Organization. We are proud to be part of that, and we intend to continue to participate with World Health Organization in the future on this project.
You know, we talked at the beginning about how our partnership with the World Health Organization is so important. Ana Velasquez and related departments like Ali Velez and Oxygen. I know one of our friends on board today is Lucio Brito from Brazil. Lucio, I don't know if you saw my chat note, but we've opened your mic. You might tell about some of the great work you've been doing. Lucio, I don't know if we can, if you're available to speak. There you go.
Tom, well,
he's there.
Okay.
Go ahead, Lucio. We see your mic open. We don't hear you. I know he's, maybe you can get that righted, Lucio. He's been working not only in Brazil, his home country, but also been sent by WHO to other countries to in the Latin American region, notably, and advising people around the world about PSA plants and other challenging things around oxygen. Oh, he's not able to talk. Okay, Yadin.
There is another person, Chandni, on the chat box that is very interesting, working as a nurse educator. Extremely good connection for us to understand how technology can better serve nurses and patient care, and would like to collaborate, participate in our work. So 2 points. One, we have put our mailbox address in the chat box, Tom and myself, for you to connect us. I think that this is extremely important link between the engineers and the nurses to improve outcomes, and would love to see that we work together on providing some educational programs to meet that. So exchange of knowledge by inviting clinical engineers to nursing circles and vice versa, inviting you to clinical engineers webinar to address what is that you need and how can we help you will be great. If you have opportunity to push the raise hand button and would like to comment specifically, I'm inviting you at this point to make comments.
Yeah, Dean, while people are doing that, we'll put the link in here, but many of you are aware on the CD website of all these webinars in the past couple of years I was talking about. For example, and I'm going to get back to your example, working with nurses, we had several competency webinars in 2020, best practices from various presenters around the world, various colleagues. Mainline health technology management, cost effectiveness, quality and safety, innovation, and new processes of care, partnering with clinicians like doctors and nurses, digital health to improve care, health technology regulation, policy and legislation, how to communicate best with decision makers, and partnering with allied health, the full range of the healthcare delivery team. So I'll put these links in here so that folks can look that up. Over.
Great idea, Tom. Thank you. Some of the individuals are unable to use the audio channel here. I don't know why we have technical difficulty, but I see Herman on the chat box suggesting to increase. Oh, great. Chandni.
Hey, good evening, all of you.
Fantastic. Great to hear your voice.
Yeah, thank you for inviting me in such a great platform, and it's really appreciated. And I'm working in the nursing education department, and currently I was listening all the talks, and I'm really interested about this topic because this is the need of an arts. We should collaborate with each other so that we can do something good in our healthcare sector. Our basic agenda is to achieve success rate in a patient outcome. As this pandemic collapsed all the system very badly. So I really appreciate the efforts you are putting towards. And I'm really interested, the comment you have shared just now that you would love to share the education program with us. I really wanted to have one of those so I can help my team to improve in the technical manner.
Great, great. You can't imagine how much I appreciate you coming forward and in interacting with the group. We all feel that nursing is our best friends in the point of care, in the hospitals, in the clinics, and we work together on a daily basis. We would like to understand how we can do more for you and how can you do more for us. So to work on specific project might be another way of saying beyond the education. Tell us where are you located,
right now I'm in India, Delhi, but previously I was in USA, California, and I have completed my graduation from Gatson University. So that's why I'm very involved in the global platform. So I love to be a part of yours. And yes, definitely, I would love to be a part in any of your projects.
So let's think about how can we get nursing groups involved with our groups, and we'll follow up. We don't have to discuss it right now, but we will follow up with you. Thank you very much. That's very helpful.
Thank you for inviting. Thank you so much, sir.
Yadin, I did send to everybody this, many had it, but some didn't, this review of the last couple of years. And I only bring that up because it tells some of the success stories, not about our organizations. Yeah, we're thankful to be successful, but about individuals like the lady just speaking, and well, from her country. For example, global health technology recognition case studies, success stories is really what they are since that publication we showed earlier. For example, Dr. Dan Clark is on the line from UK today, but he got the Order of the British Empire for the National Health Service COVID response for clinical engineers in his part of UK. You led an effort to get donations of ventilators from China to the US a year and a half ago. As we already said, Ministry of Health Bangladesh officially recognized the profession, began filling positions in the past couple of years. Ministry of Health Paraguay has continued to expand its work in health technologies really around telehealth and so forth related to COVID. And then there's this whole panel about the work of AMTZ, Andhra Pradesh MedTech Zone, a national entity in India that's manufacturing medical devices, but it's doing so much more. It's been involved with policy, maintenance, credentialing, publication, and all kinds of manufacturing, as well as not only for India, that's had its challenges like we all have, but also they're serving the countries around and outside of India. So just wanted to make that pitch. Over to you.
Every comment is something that we are recording and will follow up. So I do appreciate those of you who are coming forward and participate and interact and engage. We will follow up with you. And as I said over and over, you are encouraged to follow up with us as well. Any other hands raised?
Eva
Yadin,
from Poland.
Yadin,
Yes, Rosanna.
yeah, I would like to state a bit about the nice insights from Elliot, mostly about reverse innovation. This is a topic we have discussed with some of colleagues here and someone who are not in the meeting right now, Basit Abdul, Abdel Basat Kalas, and Miladen Poluta. Reverse innovation is certainly strong bridge for us to achieve solutions through e-health, telemedicine, and also other types of topics of our experience as clinical engineers. Thank you.
Good comment. Let's
Yadin,
go-
Eva from Poland is available here to speak.
Absolutely. Let's go ahead to Poland.
Eva, I think you can unmute yourself and speak.
Okay, sorry.
Yeah.
I would like to continue about the collaboration with nurses, which was mentioned a while ago, and I would like to present my point of view and tell about my role in clinical engineering working as a partner of physicians, because I work from the very beginning. I work in medical, in hospitals, as a partner of medical team. My role from the very beginning was keeping care of the equipment, of course, but not only. My very important job is to prepare studies and to help in interpretations of results. I work in neurophysiology, in electroencephalography and electromyography, and I am involved in everyday studies with patients and in preparing results of studies, and what is the most important is interpretation. So I think that it's an aspect of clinical engineering which is not very often discussed in our meetings. It's a role as a partner of physicians. So my position in this physicians is that I am from many years. I am in a board of Polish Society of Clinical Engineering, and I am from twice elected as a president of the largest division, and I also take part in education. So it is very important task, because it is in Poland there is a program of education for physicians who want, physicians and also for technicians who want to get a license to be be a specialist in electroencephalography or electromyography. So I take part in these courses. So I think that it is very important role of clinical engineers, except of all which are more often discussed, and maybe there are some other peoples who have such experiences to share, because it is from my very long experience, it is very, very fruitful to learn physicians our point of view, especially for results of studies. Thank you very much.
Iwa, the comments you're making is very critical for the understanding of where we go forward. And you basically saying that maintenance, repair, and management of medical equipment is conventionally in the past a major part of clinical engineering, but you're pointing to something of a very interesting opportunity for future clinical engineering to understand where else can we help. And you're pointing specifically on interacting between the equipment in the EEG study, neurophysiology, interpretation of results, and patient. We are not suggesting to replace the role of the clinical group, but to join them and help them and be part of the education, as you said. This is an extremely important opportunity. We did talk about the short availability of a worker in the healthcare delivery, the stress that is increasing on them, and how clinical engineers can come and help with that. So that is important point that we need to keep in front of us and educate our own community about such opportunities. Thank you.
Yes, of course, it is very, very important, but of every task are very important, of course. But I think that it is necessary because due to the very complication of equipment and presentation of results and many results, I think that it is very important role to help physicians to interpret results.
Good point, very good point, yes. If you would allow me, I'd like to jump to Fabiola for some comment and see, in your experience, Fabiola, such opportunities of educating clinicians about technology exist in your practice? Do you see that happening, or does it happen?
Well, I'm honored to be one of the first biomedical engineers trying to teach and trying to share the knowledge with the partners in clinics. I worked in two very important institutions in Mexico before becoming an academic, and I could see how the clinics are on the same place than like as we are. I mean, they are eager to learn how to better operate their equipment, but also how to optimize their functioning and how to improve the way they operate the equipment. And I'm talking about over 20 years ago. So from them to now, I've seen how the clinics are approaching to biomedical engineers at hospitals, and not with a face that seems that we are better than you, but also that we are in the same team and the same field, and we have to help each other. Now, more than ever, because of the exploding technology developments that are arising at the hospitals and the lack of time, sometimes they have to study in deep enough the possibilities of the technology. So I think we are living in a very important break point to move ahead and to make a very important teamwork with clinicians, but also with administrators and with the financing team at the hospitals, and in working together, propose optimizing solutions to the technological problem at the hospitals. But I think it's important, and we are at the doors of a new era on these relationships.
I agree. Thank you for your comments. And I like to jump to Antonio and try to tie this educational opportunity to capacity building. And you taught me a lot about that subject, Antonio. And I wonder if that would fit into what you discussed earlier in this webinar about what you're working on. And Antonio, if you can connect the two, that'd be great.
Yes, Yadim.
Perfect.
So tell me.
Initially, you talked about the program that you are working recently on, and you and I talked in Washington about the idea of getting some specific capacity building measurements into the program and demonstration of that. And earlier in the program today, you talked about some of your initiative. Now, Iwa and Fabiola is talking about what Chandani from India said, clinician education about technology deployment is something we don't hear much about, but it's opportunity for clinical engineers to come and become educator and interpreter of study results, which require additional competencies, but opportunities for extending our field. And I wonder if that fit into the capacity building and policy initiative that you're talking about.
Definitely is something that will be included because as we discussed, you know that an instrument that could use to set a baseline and to track the advancement and impact of those activities, it will be segmented in 3 parts. One dealing internally with what is related to the profession and the growth of the profession inside. The second one is related to all those other health sector activities where clinical engineers and technology managers work and take sometimes the lead in areas like medical devices regulation, health technology assessment, telemedicine, and of course, across the board, sharing information and education is a very strong part. And then the third segment is related to all those relations with institutions outside the health sector, but has a strong impact in the profession and in the health at large. And that is where public policy comes into place, and also relation with other organizations or ministries like science and technology and some other professional societies outside the scope of the health sector. So definitely each and every aspect that has been touched through the years will be included. The point is to measure how much the profession will be involved in those areas, especially in the second and the third one, and where we could take the lead and how could be more visible at the national level and the international level. My personal perception at this moment is we probably have more presence globally than nationally. And it's something that we need to start changing, because what is needed in order to grow is more national presence. But for that, we could have a very big push from what we have reached as an international group.
Fantastic. I do appreciate you lining it up and make the connection. That's what I was looking for, Antonio. That's great.
Yeah. I hope to have the concept paper organizing all these ideas to share with you, Tom, and some others, in order to start working in the outline, because I don't want to jump into some kind of evaluation tool before having very clear what we want to achieve, how we'll be using it, and start in a pilot program.
That's what I was afraid, that you are too particular about how to strategize the program. You won't let us jump.
You know, at the end of the day, we have everything we need, and we have it very clear. Probably what we need is to put in a more organized way.
Yeah, no, Antonio, that's great. I'm looking forward to for you to share this concept paper as we talked in Washington. That would be great.
Definitely.
Tom, as the audience getting to have better understanding what are the challenges and why they need to get involved and what they can bring to the table one by one, maybe you can one more time talk about where are the opportunities for individuals to come and join.
I want to do that in a minute. You know, I want to talk about that. I want to talk about credentialing a moment, but I also want Elliot. You gave a grand challenge to this group in 2019 around implementing policy. Can you talk about that a little bit and what happened since then?
Yes, well, the grand challenge really was to start using international standards to help converge telehealth and telemedicine so the data can be reutilized and used for public health reporting and global health reporting, localized planning. We only barely started that with Rosanna, Pedro, and a number of our colleagues before the pandemic started. And also, telehealth and telemedicine spread globally. And within 2 months, everybody was doing something called telehealth and telemedicine. The good news is that many physicians and patients have become used to using things like Zoom or texting or email to have consultations or telephone calls. The bad news is that the horses have escaped the corral, and all around the world, people are doing things different ways. The opportunity, I think, still exists for us to come back to the table and help organize that in some a meaningful technical way so that telemedicine and telehealth begin to converge as many other e-commerce solutions have converged. An example would be a global travel where one can find information about hotels. Another example is ATM networks where information can be shared about banking and facilitating sharing of information. We're going to have to come back to this also because machine learning and AI require normalized data. And therefore, we're going to have to, at some point, bite the bullet. So the grand challenge is still there. I think as we look towards a post-COVID world, hopefully we can make an impact in that area. And we certainly have a seat at the table, I think, that allows us to have that dialogue.
Thank you, Elliot. I mean, what I was thinking is, once again, Elliot issued that grand challenge in October 2019. You know, in the years prior, we had seen some countries embrace telehealth in some wise ways, many not. And Elliot was simply saying in October 2019, this is an area where we have so much expertise, we can share it at the decision-making level. You know, countries can make a difference using these tools way more than they do now or then for in getting better clinical outcomes. Then we knew just a few months later how much telehealth has impacted the world during COVID for so many reasons, as he was outlining. So that's something to think about. Let me mention a couple of the grand challenges from just a few months ago. And this was Dr. Jitendra Sharma from India, who has run this incredible program. I outlined several of its features a few minutes ago, but he was saying, we need to get our critical medical device for COVID device designs on open source platforms. You know, Yadin and I talked about being involved with WHO on innovations, and there were so many innovations coming around ventilators, for example, that were needed around the world. You know, that's a complicated device. I'm not trying to make, you know, a complex system sound simple, but if we had clear open source designs for that kind of tool and other tools like that, you know, I think the world could be a better place. They have to be regulated. They have to meet quality and safety standards, but we can help the world do better if we can put critical designs on open source platforms and encourage innovation. Another thing Dr. Sharma said was, there's a lot of high-tech designs and a lot of high-cost designs. Not all of them, but some of them, if we had consortiums from academia and industry working with our professional global village, we could make a difference on, setting up programs better, quicker, and faster. Perhaps one example of that is that they've set up an assistive technology, replacement body parts for children and the like in India. And they've done that very inexpensively, various assistive technologies, rehabilitation technologies. If we work together between academia, industry, and the global community, we can get those solutions happening a lot faster. So those are all, Yadin, just some of the things in this plan that we're trying to figure out how to move forward this year. I'll get back to your question though. So we're going to start these regional meetings we talked about before. We're going to work on focus on capacity building, impact, and policy. We've already talked about. We're going to aim towards those very central topic focused programs after 6 months of regional meetings in October this year during Global CE Week. Another topic, and we will follow up with everybody who attended today, as well as our other board and collaborator members, now about 500 from 195 countries, to join these regional meetings, Yadin. So that's one answer to your question. A sticky problem for several years is assuring the Ministry of Health or other health leaders in a country that the clinical engineering, the biomedical engineering people serving at the point of care, including, Lucio, the technicians, that's all part of the CE practitioner continuum. You asked that question. How can we assure their competencies? And that's not, there's different models of how competencies are assured across the world. I could go into there's 5 different models. The 5th one is no model at all, but because that's where many countries are. They don't have a model of how you measure competencies, but there's 4 others, Japan and the US and others come to mind. So one of the things we're going to do, though, we're thinking about, you've heard a survey of these certain indicators of some baselines that Antonio was talking about, other approaches, and we're going to do that. That's a given. But maybe a parallel approach is our credentialing teams to create an exam for people early in their career, maybe 2 or 3 years in, some experience, not too much, an exam that will point out what competencies they're already good at and where the gaps are. And then we can create training packages around the gaps, and that'll be different region to region. So I can imagine globally we can create an exam that has 80% of what, the final exam will look like, because these are competencies that fit across all the regions. But there's another 20% that are more local to the country or the region, because healthcare is delivered a little bit differently. Things are a little bit differently. Standards are a bit different. So we can collaboratively with those country and regional leaders create these exams to help, raise the professional standard and raise the professional capability of our practitioners around the world. So those are some things we're looking at. So in conclusion, Yadin, we're going to set up these regular seminars to focus on these key issues and work towards a lot of presentations at Global CE Week. Over to you.
Great. That's what I wanted to hear from you. An important point in our webinar is to specifically share with the people the next steps and how you can get involved. I know we're getting towards the end of the second hour of this webinar, and I don't want to hold people from going to sleep over in the Pacific side of the world, or getting up early in the morning on the Atlantic side of the equation. But I suggest that we'll go around the room for one last visit with the audience, see if there are any additional comments or messages or sharing of experience or question that you may have. And raise your hand if you will, and see if our distinguished faculty have any final comments. But I would like to bring this webinar to closure since we are at the end of the second hour. So let's see around the faculty.
Yeah, one final comment, Yadin, by my side, as a way to share how to achieve opportunities. I have been working since the last 2 years with the NIH in the country, in Peru, mostly in health technology management and planning, with all the difficulties and obstacles imaginable. You can imagine, but this was sustained. And in the last months, we have been focusing on HTA applied to medical devices. Next steps are definitely aimed to telehealth and telemedicine systems. So things are engaged, topics are engaged, the intervention of clinical engineers are visible if you are able to address priorities and also engage with the stakeholders. I was reading the nice insight from Shadid, I cannot remember her name. Shanli, yes, this type of short courses, yes.
Sorry, I'm the worst pronouncer of everything. Go ahead.
Yeah, this is one of the strategies we use to apply. And I say we because this type of interventions, we did it with Toby Clark mainly, and it's a mix between short courses, training workshops, and also interventions in the field. Thank you.
Great comment, Rosanna. And I noticed something interesting. You mentioned health technology management and planning. So this is an interesting, because we all use health technology management, but you have added and planning. And I like that the emphasis. That's very important, especially if you try to address priorities, not just the assets you have right now. Very clever. I think.
And you know why? And you know why I made the point, a statement very clearly, because the way to explain, and not to explain, but to share with all the stakeholders, the decision makers in the government, planning is key. Planning is needed. Is mostly through the famous acquisition of technology.
Beautiful, beautiful.
It's the bridge.
Good message for today.
I think Luis. Comment.
Hello. Yes, well, this has been an awesome and very interesting conversation on what can we do, what are we doing, etc. I would like to suggest something that I believe is key for, I want to use a religious word, evangelization of the clinical engineering word. And that is helping societies and colleges understand what they can do and contribute with these organizations that are participating worldwide. I believe that maybe focusing on associations or societies and colleges training on how those their initiatives and projects can be published in the Congress or can be published in the journal. Just a quick reminder, because for example, in Mexico, we just changed board. So maybe we need to teach the new board or share them the resources on how they can contribute best to these initiatives. That was going to be my comment, and I believe that this beautiful and wonderful group will accomplish many very, very good things and impactful projects this year. Thank you.
Thank you, Luis. I like to point to the chat box. A very dear friend, Nicholas, in Greece, has an observation that as he is listening to what we are discussing today and looking at so many challenges, so many ideas for solutions in so many areas, he pointed out to Iwa ideas of studies interpretation, Chandani about the training of other stakeholders. Lucio is talking about technicians' involvement. He made an interesting point. Is the field too wide for clinical engineers to be competent in? Should we have a department with different division? Nicholas is always great observation. I appreciate your comment. And I think that we need to discuss this further, especially as it relates to credentialing of professional competencies. Tom, any additional final comment? Fabiola, I did not invited you to final comment.
Okay, thank you, Dr. Jadin. Well, I just want to emphasize the importance of the feedback from the audience. We have 2 hours to share thoughts and wishes, and we are doing our best to achieve them. But as we have stated, this is an evolving procedure and process more, and we need your feedback. So please share them. And the more we hear from you, the better tools we will have to develop the best strategies to achieve our goals. Thank you for being with us today.
Thank you, Tom.
Very little I can add to the wonderful, wise words already. I'm delighted that we had people, as I mentioned at the beginning, from all 6 WHO-defined regions of the world. And, be a part of your society. And even if you are, you may also want to, anyway, bring your friends to these regional meetings. Like I said, some of them we will facilitate, others we will ask the regions and the countries within that region to facilitate, so that your voice can be heard and we can make it better. Yadin.
Absolutely. We have started 2022 with forceful session here today. I do appreciate the extremely expertise demonstrated by the faculty and share with all of you, with the audience who came through and help us to bring ideas and discuss conventional as well as new thinking in the field. It was great, from nearby as well as faraway places. New year, new participation, interaction here. You all invited to that. I believe that we are going to have a tremendously good year for clinical engineering profession. 2022 is going to be our year. I don't know if I'll call it the year of the tiger, the year of the lion, or the year of happiness, but I can tell you that February is known as the month of love. So with lots of love and appreciation for your involvement, thank you very much.
Thanks and bye, everybody. Thanks for joining us today.
Thank you.
Thank you. Bye.